Yeah, okay, yeah, hi. So, uh, welcome everybody to the AIOS IOC meeting. It's been happening since morning, and in the cataract session one, there was a wonderful interaction, wonderful presentations, and I'm looking forward that in this session two, we have a galaxy of speakers, and we look forward to a wonderful session with wonderful presentations from all the well-known speakers present today. So to start off, let's flag off the meeting with none other than Dr. Ragini Parekh. Everybody knows her. She is going to present on 10 tips for a good phacoemulsification. Dr. Ragini, please, from Mumbai.
Good afternoon, everybody. Thank you, Dr. Sanjay Chaudhary, sir. Good afternoon, and everybody. So, okay. Thank you so much. So, the beginner, uh, the expert was always a beginner, and selection is very, very important for good surgery. So, the correct machine, correct patient, trained personnel, a complete setup, and you have to be prepared for any eventuality to succeed. So, first of all, the way you begin and how you set up is very, very important. Now, when we start our surgery, we start with the corneal tunnel. So it is also the site of entry. So we can customize it with regards to the astigmatism of the patient because the patient wants supervision. It is also a safety valve. The corneal tunnel is triplanar, and you have to be very, very careful because if it is large, there will be leakage and the anterior chamber will be unstable. And if it is small, the wound will be tight and there will be heat burns and the wound will be disturbed. It is very important to maintain the square incisional geometry while making the corneal tunnel. So here we will see a video of the corneal tunnel. And we always make a triplanar. So this is the first groove. We go at the limbus, not the clear cornea, because the healing is much better. Of course, to each his own. And then this is the second plane where we enter with a 2.6 and dissect in the stroma of the cornea to make a tunnel. And we go inside the substance of the cornea, and then we make an entry with a 3.2 blade. Now, trying to make this as square as possible is called as square incisional geometry. That means the length is tried to be made equal to the breadth so that the astigmatism induced by this incision is as little as possible. The tunnel has to be the right size regarding the probe and also the IOL that you want to insert inside the eye. Well begun is half done, so incision is extremely important in the surgery. The side port incisions are very, very important. We use both our hands in phacoemulsifications. They have to be made with MBR blades because we find people making them with 26 number needles and bigger tunnels so that they use a Simcoe through it, but it is not to be done. The blades have to be extremely sharp to prevent a Descemet's detachment. And if you assume that you are at 12 o'clock, even if you are temporal, they have to be made at 10 o'clock and 2 o'clock, making a 90 degrees angle with each other so that your hands are comfortable while using the second instrument. So as you can see over here, so this is the side port with the MBR blade, as you can see over here. Here a side port is made inferiorly. This is for the SICA surgery, but this is just to demonstrate the side port. The blade goes into the stroma for a little bit and then the opening is made so that whatever instruments are put through it are self-sealing like the AC maintainer or they maintain themselves. Side ports are extremely important because they are again ports of entry, and if the integrity of those side ports is disturbed, then your wound is disturbed. Capsular rhexis is integral to phacoemulsification because if you break the rhexis, you break the commitment to phaco. This is important because SICS can be done without the rhexis. It is also the circle of safety, which means that your probe should be in this circle. And if it is not, and if it leaves this circle, the nucleus is thinner and there can be a PC rent. and it enables the in-the-bag IOL of the IOL, which is also the physiological position. So the capsular axis is a must. As you can see over here, this is a video, a well-dilated pupil, a great glow, and you can use the 26 number needle or the Utratas forceps, whichever is comfortable to make a good rhexis. The rhexis should be such that it just covers the optic and it is well centered and circular. So the rhexis is extremely important in a good phacoemulsification. Hydro procedures follow the rhexis and they involve hydrodissection and or hydrodelineation. The purpose of this is to reduce the nuclear size, make a nucleus, a free rotating nucleus available, and also the epinucleus which is provided is a buttress plate for safety during phacoemulsification to protect the posterior capsule. The separation or the cleavage of the various planes of the nucleus helps a complete cortical cleanup. Hence, these procedures are extremely necessary. So as you can see over here, this is the hydrodissection, which is used making a 25 gauge cannula on a 2 cc syringe. Multiple points and little fluids is important, otherwise the wave can cause a PC tear. So this is the hydrodissection procedure. It is important to plan which technique you're going to do in phacoemulsification. Stop and chop is the most commonly used. The first division is extremely important. Choosing correct parameters in case of soft nuclei, hard nuclei, different nuclei need different parameters is extremely important so that you don't mechanically push the nucleus and you are actually using the ultrasonic energy. And in case there is a problem, there's no crime to come out, assess the situation, put visco, and then go back in again. Trenching is very, very important because this is the trench which creates the first division. The trench is nothing but going with the probe and emulsifying the nucleus and creating a wall so that this nucleus can be then divided into two pieces. The depth or the height of the wall is decided on the thickness of the nucleus, and you trench till you can see a good glow. The first division is extremely important, and then which is followed by phacoemulsification, as you can see over here. So this is the trench, as you can see, a well-dilated pupil, the trench. The other instrument is the chopper, and the trench is created in the stop and chop technique. The wall of the trench is deep enough so that you can see the red glow, and then the first division takes place. Once the first division takes place, the nucleus is rotated. It is slightly tilted upwards so that the sharp pieces of the nuclei do not hit the posterior capsule, tearing it. And then again with the chopper and a little bit of trenching, two more pieces are made. And after that, all the pieces are emulsified. An apple cannot be eaten as a whole, and it has to be cut into small pieces. That is the purpose of phacoemulsification, as you can see over here. And the second half is then rotated, brought in front of the phaco probe, and with the trench and the chopper, it is again divided into two pieces. In cases of brown nuclei or hard nuclei, more than 4 pieces can be made because the nucleus is very thick and hard, and hence multiple pieces can be made to enable emulsification and aspiration of the nucleus. During the last piece, one has to be careful that the piece can go back into below the 12 o'clock position, and while coming out after the last piece, one must wait for a second so that there is no collapse. Chamber stability of any machine is extremely important for a good phacoemulsification. So the phacodynamics are extremely important in doing a good phacoemulsification. Cortex aspiration is to prevent posterior capsular opacification. The use of side ports effectively to do a complete cortical cleanup really helps you in 360 degrees removal of cortex. We use a manual AC maintainer and the Lanez aspiration cannula because we do a large volume of cases and they can be autoclaved easily. They're very economical, safe, and reusable. So as you can see over here, so once this is the cortex aspiration, as you can see, with the irrigation and aspiration cannula. The irrigation maintains the anterior chamber and the Lahn's aspiration cannula helps to do a complete cortical cleanup. In case of necessity, so you can see the 12 o'clock cortex be removed. The ports of the AC maintainer and the aspiration can be interchanged for a complete cortical cleanup. For any automated irrigation aspiration cannula can also be used. Whatever works in your hands and whatever is helpful to you can be used. During IOL implantation, one must remember not to injure the tunnel. It is okay if the incision is 1 millimeter extra, but making or injuring a tunnel causes it to become friable and it can be dangerous with respect to endophthalmitis. Correct injectable system should be used and it should be positioned in the bag, the IOL, and the visco should be aspirated. So as you can see over here, so this is the cortex, which is, so cortex has been completely aspirated, as you can see. The remaining bit of cortex is being aspirated with the irrigation aspiration cannula. The beauty of this is that even the posterior capsule can be polished and then the IOL can be put in place. So the incidence of posterior capsular opacification is decreased. This is the injection of the IOL inside the bag under the BSS because the AC maintainer is used. And the IOL is then placed into position in the bag. It gently opens. There is one slide which is remaining and I'll show you only one. It is very important to seal the tunnels. The closure of the wound is extremely important in any surgery. So sealing of the incisions are very, very important. One must observe and learn properly. A happy patient is equal to the happy surgeon. Maintaining the patient's welfare is extremely important. Thank you so much. I took about 5 to 10 seconds extra. I'm really sorry for that. Thank you so much for giving me the opportunity to present. Thank you so much.
Thank you, ma'am. Thank you for a wonderful presentation. Can I ask you one short question?
Yes, sir. Please go ahead, sir.
Ma'am, your 10 tips were very well taken. Do you patch your eye after surgery for some time for the incision to close well?
Yes, sir.
And for how long?
Sir, I work in a government institute, and even if we have any VVIPs or something living in Mumbai, when I touch any surface in Mumbai, even after having cleansed it, there is a lot of dust on it. So I prefer to patch we prefer to patch the patient for 24 hours, not less than that, because it keeps us happy. It makes us sleep comfortably at night. So the incisions are very, very tightly sealed. Most of the patients who are cooperative are now being operated under topical, especially now patients have heart disease, and there are lots of complications with injections. But even after that, we prefer to patch the eye for 24 hours, sir.
Any medications topical you give before patching which lasts for 24 hours?
Yes, sir. So we put chloramphenicol eye applicat. If the patient is not on a multifocal IOL or a PanOptics, and all the IOLs are in the bag, so we do put atropine eye ointment also, sir. We give subconjunctival at the end of surgery if the patient is not under topical anesthesia and if the patient is under peribulbar block. For topical, we do not give any subconjunctival injections. But for peribulbar blocks, we give gentamicin and dexamethasone subconjunctival injections even today.
Right, ma'am. A short comment. You're talking about the integrity of the tunnels. So somewhere we realize that when we make a side port tunnel, what is the size of your side port tunnel, ma'am? 0.9 or 1 millimeter?
No, so less MVR. Than that. It is the size of the MVR blade.
Which is
because you know, sir. Yes, sir. Yes, sir. I think the size is 0.9 of the MVR blade.
Yeah, because just an observation that when we are using 0.9 or 1 and we're using a 22 gauge bimanual, we should have a fish mouthing in the side ports. And that used to be a major cause of leakage of the chamber. So we tried with this one size higher, which was 1.2, and the fish mouthing almost disappeared. So it's just a tip if it could be of interest to you.
Yes,
and
sir,
even the main
incision, definitely it is.
And even in the main incision, we were doing all the incisions with a 2.2 incision lens. So we realized just for the integrity of the tunnel, if you make it 2.4, it makes no difference, but it made a lot of difference to the sealing of the incisions for the panel and for others.
I agree with you, Sanjay, here, because the side port incision is basically single planar incision. It's a uniplanar incision. Unlike triplanar or biplanar incision of the main port, the sizing has to be important to prevent fish mouthing and later subsequent the leakage. I think it's a very nice point.
Especially when you're moving your instrument all over the place, you're causing more fish
bimanual.
Dr. Hamas, one last comment before we move on to...
On the other hand, sir, we can also reduce the size of the bimanual cannula to 25 gauge.
25 can be reduced, but then your fluidics in and out also tend to reduce. So a best compromise is 22, and then 23 again people do use, but it reduces your input volume.
So then that will increase the bottle height and subsequent phaco-dynamics is disturbed.
I think because it comes in numbers, so I use MVR blade, which is 20 number, and the cannula 22. So 2 size bigger is perfectly all right. It works very smoothly.
What is the incision size with the 20 number?
We use MVR because MVR also come in the numbers. So MVR 20 blade, 20 number, and cannula 22. So if you are taking MVR, say 22, then cannula has to be 24. So MVR blade, which you are using, has to be 2 numbers higher than the bigger size. As compared to, we keep a difference of 2 numbers between the two.
Thank you, Dr. Havans, for that valuable input. Dr. Ajay, are you ready?
Yeah, I'm ready.
Yeah, we'll look forward to your presentation. And Dr. Ajay Paul is from Calcutta, one of the leading ophthalmologists of the country. And he would be talking to us on phaco in pre-existing capsular rent. Over to Dr. Ajay, please.
Thank you for this wonderful opportunity. I thank AIOS for having me here. Well, I'll be speaking on, as you say, posterior, the phaco in pre-existing capsular rents, and I think nothing more than posterior polar cataract is the thing which comes in your mind because of the inherent weakness and the thinning of the posterior capsule, enlargement of the specification. And generally, they have a central vertically oval defect, thick fibrous margin. You could have pre-existing PCRs even in congenital cataracts like posterior lenticulus or posterior persistent hyperplastic primary vitreous, where they have a stalk, and when you're going into the floating with the vitreous, the fiscal sign, that could have an absent PC, or it can have a very thin PC there. And of course, trauma, both penetrating and blunt trauma, are because of pre-existing PCRs. Now let's come to the phaco tips in these cases. I would say choose an advanced phaco machine, especially if you know that there is a pre-existing PCR. Keep the vitrectomy ready. Self-sealing incisions, very important. And avoid hydro procedure in these cases. If you are doing it, do it with a viscoelastic, low flow machine parameters, phaco in situ. I mean, don't move it too much. An adequate visco to support your opening that is there. Use second instrument to stabilize the nucleus. Avoid changing nucleus with the phaco probe, and do not panic. And of course, you need to have a standby VR surgeon. Let's come to this PPC, the commonest that we find when there is a pre-existing PC. There is a small hole there. I could see it pre-operatively. So I, go with all care and attention. Do not do hydro procedure just with a spatula. Go it and do a small central trench, put in viscoelastic, and then this is the hydro delineation. Separate that central part, and then put in enough viscoelastic not to hyperinflate the bag, the eye as a whole, but then keep it just enough. With the present machines, you can have the bottle height or the Centurion machine, you can keep it around 30 as the irrigation. And then as I'm going and taking, I know that somewhere now I'll meet the PC, and the moment I see it, well, there it is. I stop it here, put in a high monopolar viscoelastic, in this case, viscoat, no financial interest, but that really serves as the real plug. I can see a bit of horizontal tear, because most of the PPC tears, as they happen, they are either horizontal or vertical. In this case, it was a horizontal. I could see it, and then plug it again with methyl cellulose over viscoat. And then this was a soft, as you can, most of these cases are soft, so I can do a visco aspiration and expression, and there I express it in the visco, and once that is over, I go on with dry aspiration. As you can see, I put in viscoelastic from the side port, keeping the tear that is there. I try to identify it. It has gone right up to periphery. As you can see, it's a totally horizontal break. There you are, the horizontal break. But then now, since I've completed it, the option before me is putting in a lens which is either totally in the bag, or in this case, I'm choosing to put a multi-piece lens in the sulcus and then uh, do an optic capture. As I go and put the lens, I do lose a bit of vitreous. Then I go in with this cutter, but ideally should go from the side port. But the same, since the chamber was full of viscoelastic, I just do not put any infusion there. Then later on, I just go forward and do a from the side port a little bit of vitreous that had popped out, but then the surgery is completed. Now, this is a blunt trauma. Well, I knew it from the patient's record before the cataract. And this is a young child of 8-year-old came to us with the total cataract, which showed that 6 months back he had taken a picture where there was a pre-existing tear. As you can see, I could see there is a through this white cataract, this horizontal line. Do a capsular rhexis. Very careful that the rhexis is around 4.5 to 5 millimeters, so that in case I cannot put the lens in the bag, I can do a lens in the sulcus and optic capture. As I do bimanual eye, this is a child, 8-year-old child. As we do take the aspirate the soft cortex, there's hardly any nucleus, and you can see that is the horizontal break over there gradually, and put in. You can see the centurion parameters showing around 40 IOP. That's just enough to keep, and so that I don't have any stability of the chamber, instability of the chamber. Do a aspiration, bimanual aspiration. See the break is still there. Bimanual, yeah. As I go in now, there is a break there, and I've got the intact bag. So here I decide to go in with the single piece lens. The lens goes into the bag, and I complete the surgery. In this case, the surgery is over. So this is another blunt trauma. Well, basically, I was not aware of it, that whether there will be a break or not. But then as we go forward, I do a bit of hydrodissection, and then this is the in situ emulsification. And as I go forward, I do see there is a rupture there already. So fibrosed, the margins are fibrosed. As you can see, this is the fibrous margin of the rupture, but still I could manage to put in the lens in the sulcus without losing, without having much of a problem, and the lens goes into the sulcus. Now this is a penetrating trauma. Now this is, again, see, I can see the penetrating mark. Well, whether these the needle gave a history of needle injury. This was again a small child, came to us after 6 months after the injury, and again the same thing. I go ahead with the rhexis. As you can see, the rhexis is here. And this is the area where there's an injury. The injury mark is there, and you can see, and not know whether it has ruptured the posterior capsule or not. Do a irrigation just to take this line and take out the cortical matter. And as I go forward, I do see a big break there. But fortunately, as you can see, I'm already pulling on the margins. There is a little bit of vitreous there, so I stop it there, and then just do not go in the central part. Go to the periphery, take out all the cortex. And you can see, take out the cortical matter from the periphery. And once I do that, I go ahead with the vitrectomy, and then I have enough space there, as you can see, and put in the lens again in the sulcus. The lens is placed in the sulcus, and there, once that is over, putting a bit of triamcinolone now, yes, there, to check if there is any vitreous there. Once that is done, I know the integrity, and since I was a small child, I continue with the vitrectomy and try to get any vitreous stance that is there. Once that is done, I suture the incision. Again, as I said, it's for 8-year-old child, so I didn't want to leave it that. And of course, the last case, this was a blunt trauma. And as he went ahead, he just separated. There was a history of uveitic, and then go ahead with the rhexis. Once the rhexis is completed, I did go in and start with the phaco probe. Then the rhexis again, the needed size around 4.5 millimeter rhexis. The moment I go into the AIOS, the whole nucleus drops, and that is the pre-existing break that was there. The VR surgeon comes in and removes that. You can see that's the pre-existing break already there. So the nucleus is removed, and once that is done, put in again same, put the visco in the entry chamber and put in the lens in the sulcus. Yeah. So lenses in the sulcus. Well, again, a capture. The optic capture is done. That's the preferred method. Once that is done, the lens well set. So thank you for your patient hearing.
Yeah, that was very nice presentation, Ajay. Can I just ask a question?
Yeah, sure.
Yeah. Suppose after doing the vitrectomy and taking out everything, you find that the 3-piece IOL is not available of the desired power at that time, then what would be your second choice? You have one is hydrophilic, other is hydrophobic. Would you
no, I have not put a hydrophilic or any single piece lens in the sulcus. Definitely not. I do, if I don't have I have a stock of even PMMA lenses.
Yeah.
So I'd rather put a PMMA lens in the sulcus if the desired multi-piece lens is not available, or a SFI is again another option that I'm going for.
Yeah, exactly. There was a lot of discussion on various groups regarding that we can put hydrophobic lens. I think you have made your point very nicely clear that hydrophobic lenses definitely should not be put because of thicker haptics and rubbing on the back surface of iris. Very nicely said, sir. Can I invite any other questions, please? Now I would like to invite.
I think very well managed. But whenever there is a vitreous or doubt of vitreous in the AC, I always, after putting the IOL, as you did in the second last case, put the IOL, concentrate the pupil, and stain with the tricot to make sure that there is no vitreous in the AC. So I do not put the tricot before putting the IOL because it can go into the vitreous cavity. So put an IOL, concentrate the pupil, put the tricot diluted 1:2 or 4 to check for, and before you leave the patient to be 100% sure there is no vitreous in the AC.
And a little bit of tricot also helps in the long run, gets down the inflammation in these sort of cases where there is it. So that's always a, even if I am sure that there is no vitreous, but then a little bit of triamcinolone there helps in the long run.
Right.
Thank you.
If there are no more questions, I would like to invite Dr. Swapna Nair. Dr. Swapna Nair is going to give her talk on phaco in subluxated lens. Dr. Swapna, please.
Thank you, Dr. Bala, and good afternoon, Dr. Sanjay. Good afternoon, everybody. As Dr. Bala mentioned, I'll be talking about phacoemulsification subluxated cataracts, and I hope my screen is visible.
Yeah.
So basically, subluxated cataracts have certain attributes that we need to take into consideration before planning the surgery. First of all, whether it's a stable subluxation as it happens in a one-time trauma, or whether it's progressive like in pseudoexfoliation or in a disease like Marfan's. And it's depending on that, you decide on whether to, just do with a CTR or go in for a sutured segment as well, or go in for a complete evacuation of the lens with an SFIO. The extent of zonulo dialysis, the clock hours to which there is dialysis happening, also determines what kind of implant you want to put in. The grade of cataract, if it is slightly on the lower side, makes surgery much easier than when it's a harder cataract and you have to deal with two aspects, both the subluxation and a dense nucleus. And of course, the presence of vitreous in the pupillary area or the anterior chamber. So one of the major roadblocks is creation of the rexes. You can see that there would be dimpling of the capsule even during the initiation of the rexes. Secondly, because of the lack of traction, counter traction, then you need to make a good rexes. It's always hard to pull the rexes around. Another factor is that because there is some amount of subluxation displacing the lens from the center, we may not be able to put the pupil as the point of reference. Rather, the dislocated lens should be taken as point of reference. Like you see over here, you can see that the chamber is being intermittently stabilized by using a viscoelastic, and the rexis has been decentered to the left because the subluxation is there to the right. So that ultimately when the lens is centralized by an implant, then the rexis would land up to be in the center, and the optical center of the lens would correspond to the optical center of the eye. So these are the fine changes that you need to bring about in a rexis. You can, of course, use a micro rexis forceps to do all that. But above all this, you should be sure that your anterior chamber is free of vitreous for the rexis to happen smoothly. Now, in case there is a moderate amount of subluxation with that blob of vitreous that you can see over here surrounded by some amount of pigment, again, this is a post-traumatic cataract, and you can see that the cataract is also pretty mature with an NS3 nucleus over there. So you can see a vitrectomy being done before the placement of the hooks. So here I'm using the iris hooks, which are for vertical support of the capsule. Capsular hooks are a much better idea because they are much blunter at the point of insertion towards the capsule. Horizontal support is given by the CTR, which you can see is being implanted in the equator of the bag over here. And this provides much required stability to the lens, make sure that there's not much of movement either horizontally or vertically. Now, there are people who put capsular hooks all around, but I usually prefer to do that in the area of subluxation to lift that point up so that there is no dipping of the lens in that region. And again, the IOL is placed in such a manner that the haptic of the lens corresponds to the region of zonulo dialysis, so that would provide some amount of push to that region, centering the lens. Now, this is a much more severe subluxation. You can see that it is more than 180 degrees. Again, there is a decentered rexis being made using a microrexis forceps. And now this nucleus is not hard as the previous one, so there is a relatively good hydrodissection happening, which is very important for maneuvering of the nuclear particles during phacoemulsification. I would like to bring to your note that the vacuum and the aspiration rate all have to be slightly reduced for the to make sure that the lens does not move too much. Now, once the nucleus is evacuated, cortical aspiration is also another point which needs to be taken care of, which I'll be coming to slightly later on in the talk. Now, again, a CTR has been inserted here. But even after the insertion of the CTR, it is noted that the lens is not, the capsular bag is not centralized, because of which CTS has also been placed. So this provides an additional support to that part of the zonulo dialysis, especially because the extent was more than 180 degrees. So you can see that the eyelet of the CTS over there, the small hook-like eyelet of the CTS, it would come over the capsular margin and under the iris, and that scleral tunnel over there is for the placement of the sutures. You can see the railroading of the tenoproline happening through the scleral tunnel. And once the sutures are brought out, they are buried inside the scleral tunnel. Now, this has caused the shift of the capsule to move towards the CTS placement. And you can see that the IOL is kept in the bag. You may tie the final suture of the CTS towards the end once you make sure that the IOL is in the bag, and you can also align the optic in such a way that it's exactly centered if you tie the suture at the end. Now, suppose you have an unsalvageable lens like this. You can see that it's grossly subluxated more than halfway down the pupil. Then the only option is to completely remove the lens, evacuate it along with the bag, and go in for a scleral fixated IOL. So you have your scleral tunnels made diametrically opposite, and along with the insertion into the vitreous with an MVR blade. So I use an end grasping forceps, and this is a 3-piece foldable intraocular lens that is going to play the role of a scleral fixated IOL. And once the first haptic is grasped and slowly brought out through the first tunnel, and it is put inside the small scleral aperture that is made, and then the second haptic is passed on to the end gripping forceps and again brought out to the second tunnel and inserted into the scleral port. And now the main port is sutured, and then the glue is applied to seal the scleral tunnels. I also use the glue to seal the conjunctiva on over both the scleral ports. So it's very important to make sure that the haptics are not tilted a bit, or the lens remains in a horizontal plane. All the rest of the ports are hydroed. Now, if you have flax, it's very, very useful in a subluxated cataract, because you can pre-program the rexis to a decentered portion. You can see the subluxated lens here in the OCT picture, where more of the equator is exposed on the left side compared to the right side, and therefore the rexis has been decentered more to the right side. So now there's a pre-programmed rexis. You don't have to tug, you don't have to pull. Also, there's some undulations on the capsule, if you can see in the OCT picture. So you may need to adjust your delta a bit upwards and a bit downwards more than what is usually programmed, so that the entire capsule is covered. So you have a pre-programmed rexis, you have pre-nucleotomy done. So the maneuvers decrease a lot, and the chances of error are also drastically reduced. Now, this is the patient on the table. You can see how the free-floating rexis comes out, and all you need to do is a good hydro so that you can pass your CTR in. So this is no a way out of a CTR or a segment. It's only that some parts of the surgery are made much easy, but the application of a CTR or a CTS is inevitable in most cases of subluxations. There are few subluxations where you can just do a phaco under low parameters and get away with it, and the lens remains as such without tragedy. So now coming back to the part where I said that after phacoemulsification, now here the maneuvers are much less because there are nucleotomies made. So you just need to be very sure that you are separating the nucleus completely, because sometimes the nucleotomy doesn't go all the way down in flax, and you need to do a manual separation of the posterior plate. And the emulsification carries on. In cortical aspiration, some of the important points that need to be noted, especially in the placement, after the placement of a CTR, is that the cortex may not just come out very easily. You may need to hydro the cortex a bit and then pull it out radially for it to come out easily without disturbing the CTR. So now there is the placement of the lens in the bag. So some of the aspects, some of the take-home points that I would like to drive in is that the parameters except energy need to be lowered a bit. So if you usually use a 32 AFR, please bring it down to 24 or 28. Now, if you're using a vacuum of 600, you can get down to 250 or 300. So this is to maintain the stability of the lens. There should be both horizontal and vertical capsular support during phacoemulsification. And depending on whether the subluxation is gross or it's progressive, you can use the placement of permanent segments in or permanent rings with sutures in the capsular bag. And of course, skill regarding glued SFIOL is very useful, especially if you go wrong in any of these steps and you need to remove the lens in total. Thank you very much.
Thank you, Dr. Swapna. That was a wonderful presentation. Just a small question to you, ma'am. There has always been a discussion that a CTR has to be placed, but placed after the hydrodissection or placed after nucleus removal. What,
Yes, I think
where do we
that is
stand now?
a favorite question in all the forum where
Yeah. So where do we
subluxated
stand
lenses are
finally
placed.
now?
Yeah.
Where
So
do we stand?
I would always suggest that the CTR be placed after hydrodissection. Now, the question is whether it should be placed during the initial part before nucleus emulsification, or maybe after you have gone through the nucleus emulsification. Again, that depends on the extent of subluxation. I usually try to place an early CTR in most of the cases because I want my back to be stable. I don't want the capsular equators to be coming into my phaco probe once half of the nucleus is eaten. So that is one of the major reasons I prefer an early CTR to a later one. But then there are some cases where the nucleus is very stable and you can get away with it, and maybe only during cortical aspiration or just to center the lens you may need to place a CTR.
Yeah, so basically one is to center the lens better. Number two is to stretch the posterior capsule so that it doesn't stay floppy and comes up and hits the tip of the phaco and you have a ring. So I think by default it is accepted now that it has to be done before. I think the panel agrees to that. Dr. Harbans?
Dr. Lal has a question.
If you see the crenated margins of the subluxated portion of the lens, that means some general fibers are still attached. And these lenses are far more stable than if there's an absolutely smooth margin of the subluxated portion. So there are some granules attached, you will find there is no vitreous. And these lenses, you can delay the putting the CTR. And once the last fragment is prolapsed from the capsular cornices, put on a viscoelastic to push the posterior capsule back and to the lower parameter, then you can put the CTR afterwards. But if it is totally subluxated and vitreous is collapsing, then of course you need to be more careful and put CTR before.
Thank you, Dr. Harbans. And now may I have the privilege to invite none other than Dr. T.P. Lahane, sir. And Dr. Lahane, sir, would be talking on managing a rock-hard cataract, phacoemulsification, and SICS. So over to you.
Sanjay, thank you very much, Sanjay, Dr. Balla, Dr. Ajay, Dr. Agini. I'm going to speak to you on the rock-hard cataract. And here I want to tell you that my financial disclosure is nil. And I want that this is me versus me. That is, I should do SICS or I should do phaco. That is what I always feel, and that is what I am going to present to you. Next. So there are the challenges. Now, when there are the challenges, what are the challenges? The capsule cannot be seen. No glow for the rexis. Weak jonular support is there. More endothelial damage can happen. A difficult trenching eye. And all these things are there. There is and because of that, I think we should now think in this term that yes, the phacoemulsification or the SICS. What is your choice? So that we'll have to think. And now see, small incision cataract surgery. If we are going to do it, then the Blumenthal who taught me the surgery, I went to him to learn the surgery in 1996. I was with him for near about, you can say, the 1 month, and he taught me surgery there. So here it is a basic thing is the sclerocorneal self-filling incision. Then less learning curve is there, connect curve is there, less low cost procedure. There is no cost, less machine dependent, less damaging to the endothelium. Next. Now here you will see what I am doing is removing from the 5 to 6 millimeter tunnel, I am removing the 10 to 11 millimeter of the lens. That is what is there in the SICS. And see in SICS. So if you see the phaco, we have different types of, you can say, techniques, but here the visco expression, Blumenthal, phacoemulsification, snare. So these wire vectors, all these things are together in the at this juncture, and so that all types of SICS can be done there. Now, what I want to tell you, how to do it. So funnel shaped incision is there, and this funnel shaped incision, this is a larger one. The lens is larger one. We are removing it from the funnel shaped incision. Now the next. Now see this is essential steps are safe. The CCC, pre-nucleus, and the like the phaco only the tunnel is the difference. Now see, this is the hard cataract, and you can see this is the like both, that is the cortical and the nuclear cataract together. Now you will see what I am doing is the incision in the always in the I do in the sclera well the blackness of the limbus ends and the pockets. So very integral part of the surgery is a pocket, and I am making the pocket. You will see here the rexis. Now it is not must that rexis should be done, but yes, the rexis nowadays I do the rexis. Now this is the old video. So here again you will see the uh, this is the tunnel funnel. So now see, whenever you are making the pockets, pockets are very important. And here I have made the pockets, and then there is a hydrodixation. And in the hydrodixation, what I will do, I will just bring the nucleus in the, now you will see very large nucleus, also the hypermature calcified cataract here. And now I am just removing it with the, I can say the glide. So glide, now this is a user and throw glide. See here, the nucleus is coming out, and here you can see the cortex also has came out. So this is done whenever I am doing this such type of cataract. Now this difference between SSS and phaco is for the hard cataract. Phaco you will have to, like you can say, and here you will have to remove. So phacoemulsification, see here also advantages are definitely there. Incision is very small, the astigmatism is less, recovery of this is you can say the is earlier, the recovery is earlier. Now how you manage, there are so many machines. It is not required that you should have a good machine and all other, even basic machine can work for the hard phacoemulsification. Now here you will see the what I am doing is the trench. See, whenever you are doing the phacoemulsification in the hard cataract, the trench should not be only the tip breadth, but slightly more. So here you will see I am just removing from the side this one, and the trench is more. Now once this trench is more, then I will have to go near about 3/4 deep in the center and also in the periphery. So again you will see when that is done, and then after doing the trench properly, you will have to separate it. So here I am separating the nucleus. Yes, here you can see the, as it is a, you can say like a drill. So like that it is a very hard cataract, and you can use burst and hyperburst mode, hyperpulse mode. Here you can see now. Again the I'm going inside on one corner on one side, and the other side my chopper is helping, and you will see the posterior fibers. These posterior fibers are rubbery, leathery fibers, and that you will have to separate. Now, what happens here? If you are separating is too large, it means separation is if too big. What happens? It stretches the zonules, and there is a PC tear. So you must know that how to separate. See again here, the separation. Yes, you must see like V. Now, and this should not be larger, which will give rise a U. So that is what is done, and then separate on the other side. Here you will see again the fibers are always there in the
Hello.
posterior side, and these
हेलो
fibers.
हेलो हाँ मैं डॉक्टर भल्ला बोल रहा हूँ.
Now see here again the case. You can see what I am doing is now he in my this one I am chopping it. See here, my tip is going in. See, and then I am chopping. So once the tip goes inside, then you can see this. This is the vertical chop I'm making. But whenever the tip goes in, you will have to fix it. And that time, see here, you are in the vacuum mode. And once you are in the vacuum mode, then again you can separate it. You can see on this side, the vacuum is increased to 500 to you can say more than 500. Here again you will see it is a 650, 780, 88 like that, 791. So the vacuum is increased. Now see the another this one. The whenever you are making the comparison, now see here, I'm doing the on left side it is a size. It is just a comparison. Right side I'm doing a phacoemulsification. Now when I'm doing this, what happens here? You will see the I'm separating here. Now see, phaco is always better than SICS result wise. But whenever you are planning, and if you know that yes, you can do the phaco also, there is no problem. But where you feel that this phaco, you should not do it, or you can have some alternative, that time you can definitely think that yes. Now ball out each other. Now what happens? The wide subluxated cataract here I am doing, and on the other side you will see the the other type of cataract here, what you see that I am doing. Can you see this? So 2 cataracts I am doing, and can see here how now here I am using the ring. Just now you have seen the subluxated cataract. Now here what happens, I have done a small axis and I am doing the SICS. So what I am doing, I am doing the phaco so that the pieces of the nucleus will be smaller one, and so that I will remove the pieces from the SICS. It means the phaco is helping me in the SICS. Now here you will see I was doing the phacoemulsification, but there was a PCTR. Now the SICS is helping me in the phacoemulsification. So here you will see this SICS has helped me, and I'm removing the pieces instead of those which are going behind. So SICS or phaco, that you should decide, and this is a combination work best as the 2 techniques complementary to each other. It is not a different techniques; they are complementary to each other, and so these techniques works better. And I think if you are master in the both the techniques, that is always helpful. So thank you very much. I think this is what I want to say.
Thank you, Lawrence sir. That was a wonderful presentation. But still, a phaco surgeon who is an exclusive phaco surgeon will say phaco is better. Who is an exclusive SICS surgeon will say SICS is better. You are both, so you can analyze things better.
Sanjay, I agree on this issue. Those who are the phaco surgeons, they always say phaco is better, and I also agree that phaco is definitely better. But in some cases where you want that phaco is not possible in such situation, and if the phaco there is a PCTR, instead of asking retina surgeon to remove, you can remove by SICS. It means that may be a dependent surgery on your colleague, and this is not a dependent surgery that if you learn it. So it is not that there is some ego in the phaco and SICS. What I want to give a message that yes, phaco is very, very superior surgery, but yes, SICS is also a good surgery, and that can definitely help whenever you are in difficulty.
Right. Thank you, sir. Thank you so much. Dr. Bhalla, can you please invite the speaker?
So after that brilliant talk by Dr. Lihane, I would like to invite Dr. Somshila Murthy, my dynamic colleague from Scientific Committee, AIOS, to give talk on phacoemulsification and uveitis. Dr. Somshila, are you there?
Yes, Dr. Bhalla.
Yeah.
So am I audible?
Yeah,
Yes.
you are audible, but you are not visible.
Yeah, so just having a problem with doing both video and PowerPoint.
Okay.
So I'm sacrificing the video. And also I have a audio for my video, for my PowerPoint. So can you please let me know what are the issues in uveitic cataract? It's not really just about performing surgery through a small pupil, but we must also remember that the patient has a disease which we need to take care of. So the first and second aspect that I need to look at is what is the indication of surgery and what's the visual prognosis. So most of the time the indication of surgery is of course to improve vision for the patient, but sometimes we might be operating in order for us to have a view of the posterior segment, and therefore the visual prognosis must be explained in detail with a lot of chair time taken up to counsel the patient so that they have realistic expectations post-operatively, and also to understand that the disease does not end with removal of the cataract, but the inflammation needs to be tackled separately. The timing of surgery is always extremely crucial, and this should be done in a window when the inflammation is inactive, even by using pre or perioperative steroids. The surgical technique needs a few modifications from our standard cataract surgical techniques, and also including the choice whether we can place an intraocular lens or not, and what type of lens can be placed. For example, in pediatric patients less than 10 years or 12 years of age, placing an intraocular lens is contraindicated. Post-operative regimen is extremely important to control the inflammation and manage other complications such as glaucoma, cystoid macular edema, and so on. Otherwise, if left untreated, these would lead to loss. So the timing of surgery, as I mentioned, should be during an inactive time. It's very easy to see what is active disease, but how do we know that they waited enough time? So it's not just enough to wait by rule of, by the protocol of waiting for 3 months from the last inflammatory episode, but it's more important to look for lack of cells, no cells in the anterior chamber, although flare may persist. And I also look at the appearance of the normalcy of the iris crypts. That's a very good sign for me to realize that if the eye is quiet. The actual surgical technique consists of two important parts. The first is management of the synechia, and the second is the actual capsular rhexis and the rest of the phaco procedures. So the synechia can be released just by simple viscodissection in cases where there are very small or thin synechia, but most of the time this is not possible. So we have to use some or the other technique to expand the pupil. So this can be as simple as sphincterotomies using vanas or a micro scissors. We can use collar button devices such as Kublin's hooks, as well as iris hooks to keep the pupil dilated throughout the surgery. And we can use rings such as the B-hex ring or the Manugian ring. The capsular rhexis and the other phaco procedures are pretty much similar to most of the other phaco surgeries that we are so used to. So this is a patient who's a 35-year-old patient with VKH who had a complicated cataract and a very shallow anterior chamber. Notice that the patient has almost 360 degrees posterior synechia. So after making the side ports and injecting viscoelastic with the help of a Sinski, there's a space selected between the anterior lens capsule and the synechia. And the pupil has opened up a little bit, and further opening up the pupil simply with the help of Kublin's hooks, doing it very slow, taking care that I do not rip the iris because it's very fragile in young patients. And after initiating the rhexis with the cystectomy, the rhexis is completed with the help of a microforceps. So after that, most of the time, this amount of pupil size is adequate for us to safely perform cataract surgery, especially since the cataract is usually very soft in these young patients. So after hydrodissection, you can notice that the nucleus is maybe grade 1 to 2. And by simple, almost like a phaco aspiration or with minimal energy, the entire nucleus can be got out in toto. The next part involves a very thorough cortical cleanup to ensure that we do not leave any of the inflammatory cortex behind. As you can see, it's a case with a very heightened red glow due to VKH or a sunset glow. So a single piece hydrophobic acrylic lens is placed in the bag, making sure that the optics are well tucked behind the rhexis, the haptics are well tucked behind the rhexis. And finally, at the end of surgery, after cleaning up all the viscoelastic, I usually give either an injection of intracameral decadron, or based on the case, sometimes I might give a posterior subcutaneous injection or an intravitreal triamcinolone injection. But all of these patients would be patients where I've established that they're not steroid responders. This is another case where the synechia are much harder. The cataract also has a more advanced density in terms of the nucleosclerosis, the total cataract. And there's a large pupillary synechia with a membrane which actually goes even behind the iris. As you're pulling it out, you can see that. So these membranes should be carefully removed. And we use 4 iris hooks to nicely dilate the pupil. And once we do that and have a very good exposure of the cataract, which is hard, the further cataract surgical procedures can be done fairly easily with the help of a very good rhexis followed by phacoemulsification. This is a 29-year-old patient who had recurrent uveitis, is HLA-B27 positive, and this patient has a small bound-down pupil with hardly any vision due to an occlusive membrane. Also, you can notice that there is a peripheral iridotomy due to past episodes of secondary angle closure or pupillary block. So this patient underwent cataract surgery. First of all, after injecting viscoelastic, using Sinski, a small portion is selected where you can insinuate the Sinski below that. And then through that, we can apply Kublin's hooks, as you just saw me do. And after staining the capsule, we can have a very good capsular rhexis. Notice that this patient also has a fairly soft cataract, being a very young patient. Not as soft as you would expect, because with the uveitis, the cataract is slightly harder than what you expect for the patients of this age. So after that, it is fairly easy to tackle the cataract using phaco, and just that the pupil is smaller. So you should make sure that you don't trap it with the phaco probe. Otherwise, you know how difficult that gets. That makes your surgery. So once again, after complete cortical cleanup, In this particular patient, we selected to inject Ozurdex at the end of surgery. So after we inject the intraocular lens, an Ozurdex injection was given to this patient. So the way the Ozurdex injection helps is that it takes care of the acute postoperative inflammation as well as cystoid macular edema, which is very classical to see that happen within 3 to 4 weeks after cataract surgery in many of our patients with complicated cataract. So this is the Ozurdex injection at the end of surgery. So to conclude, well-done surgery is only half the battle. We should understand the type of uveitis. We need to work very hard for the pre, intra, and post-operative control of the inflammation. And we should be expectant of and expert in managing the post-operative complication.
Thank you very much, Dr. Bala, and thanks to the organizers for inviting me. And it was my privilege to give my talk after Professor Lane, and I just enjoyed his talk about SICS versus phaco. So I was just thinking about that when I was showing my cases, that just to point out that it doesn't matter whether we do SICS or do phaco, depending on the case, it should be very safely done and well done and take care of the inflammation. Back to you, Dr. Bala.
Thank you, Dr. Somshila. Dr. Somshila, what is your standard post-operative regime in a case of such a uveitis? How long and what do you continue with?
So typically, most of the patients, I would have just stepped up the steroids perioperatively, maybe a couple of weeks if I have the time to, if they have given the time to me to plan it. Or definitely post-operatively, I would step up the topical steroids to maybe 2 hourly or 1 hourly. If they're not steroid responders, I might use difluprednol instead of pred acetate. And I usually always use atropine for my patients post-operatively.
For how long?
So I use steroids in tapering doses, so at least for 6 weeks, and 1 drop a day goes on for the first 3 months minimum, checking the pressures, of course, and atropine at least for the first 3 weeks, if not longer. So that helps me a lot in controlling the inflammation. Of course, the visual rehabilitation with glasses and all will be a little delayed, but at least this way I can avoid the inflammatory complications such as cystoid macular edema.
And do you use any NSAID?
Yes, I do use NSAIDs, although I think that they have more of an adjunctive role. Most of the patients I usually use Nepafenac based on the formulation either once or thrice a day, but it's more of adjunctive. And many of these patients would also be on their regular either immunomodulators or a low dose of oral steroids postoperatively.
Isn't there a chance that you're using atropine for 3 weeks, the pupil stays dilated and fixed subsequently?
No, I've never. So that was initially my concern as well when I started practicing. But I've had most of the pupillary reaction, like you said, more with hometropine. So I switched to atropine. This was advice that Professor Amod Gupta gave, and I think it works well. So initially it will stay like that, but later on the pupil comes down and you get very nice near normal or whatever kind of pupil you have for these patients. It doesn't
so
get
atropine drops or atropine ointment?
I use atropine drops.
And once a day?
No, initially I use it 3 times a day for at least the first 2 to 3 weeks. But when I say that, it doesn't mean each and every case. For example, if you have a patient with very well controlled only anterior uveitis like HLA-B27 or something like that, then there I don't think we need to use, maybe we can use hometropine, or say Fuchs uveitis, I never use cycloplegics. So it does depend on the basic underlying etiology of uveitis. So we can have, to some extent, we can have guidelines, but it can't be one hat would fit all. We'll have to change it based on the patient and the indication.
Thank you.
Indications of systemic steroids in such cases before I go to Amit Purwalia.
Yeah. So systemic steroids, I try my best to make sure that the inflammation is controlled, because I think now most of us in uveitis practice, we try our best to use more of other agents and less of systemic steroids because of their side effects. But having said that, if I have a patient who has a very bad inflammation, I will use something like 60 milligram daily for maybe 1 to 2 weeks preoperatively, and then start tapering it down. Sometimes they do very well initially, and then day 1 post-op or 1 week post-op, they come back with inflammation. At that point, I'll use systemic steroids for them. So most of the time, the idea is to have them very well controlled so that you don't need to use a whole lot of systemic steroids.
Right. Thank you so much.
I have a question for you, Dr.
Yeah, Amit.
Permit me.
Yeah.
Hi, Amit.
Actually, Yeah, hi, Sunshila. Regarding systemic steroids, this is a new trend, I mean, which a lot of studies also were there, that immediately after the surgery, you give a high dose, one single dose of say 100 milligram of oral steroid, and then start from next day onward 60 milligram and taper it. So what is your take on that? And second thing was you mentioned about intracameral steroid you inject in some
Right.
cases.
Right.
So intracameral dexamethasone you mentioned.
Right.
So what do you use in intracameral dexamethasone? I mean, endothelial toxicity, or is it a normal dexona what is available?
So we have a dexamethasone which is used by our anesthetist, which is preservative free. And otherwise, whatever the retina guys use for intravitreal usage. So
That is
most,
very expensive. The Ozurdex.
Ozurdex is the one.
Ozurdex is intravitreal, not intracameral.
no,
Can
not Ozurdex. I was just talking about simple dexamethasone, injectable dexamethasone, preservative free. So we do get that. We can stock it in our operating room. If not, the intravitreal dexamethasone that the retina folks use for some of the cases. So it does have a preservative, but although it's off-label use, I've not yet seen a case of endothelial toxicity. Again, this just gives exactly like you said about giving 100 milligram of Vizolone post-operatively. This gives a like a kickstart to the anti-inflammatory effect of whatever other medication we use. And that is the one thing that has changed my outcome for my patients. So very strongly sold on the idea of using intracameral steroid.
Thank you, Sunshila. So can we just move on and have the privilege of having Dr. Kumar, doctor? He has some emergency at home and he wanted to do an early presentation. So can I have Dr. Kumar, doctor, over? And Dr. Kumar will be talking on small is tough, our champion from Mumbai.
Thank you, Sanjay, for adjusting, and thank you, Professor Balla, and the rest of the team. You can see the presentation now. So the topic is small is tough. I'm going to show two very interesting cases. Some of you may have never seen it, and some of you may have seen it. But let's see what you feel. Small eyes can be classified according to anterior chamber depth and axial length. This video will demonstrate the challenges found in two cases, extremely short axial length and a small ACD, namely the nanophthalmos and microphthalmos with an iris coloboma. A unique complex case, a software engineer by profession with high hyperopia was referred for refractive correction. On examination, her best corrected visual acuity was 20 by 40 part in both eyes with a correction of plus 12 diopters. On slit lamp examination, she had a normal sized cornea in a very shallow anterior chamber, and gonioscopy showed occludable angles with a normal IOP. She underwent a prophylactic YAG PI in both eyes. Dilated fundus examination revealed heaped up optic nerve head and retinal vessel tortuosity with an attached retina in both eyes. OCT macula was normal in both eyes. A detailed imaging was performed on tomography, optical biometry, and a corneal wavefront and an ocular wavefront analysis was done. What the test revealed was indeed unique and surprising. Her white-to-white diameter was 10.7, her ACD of 2.68, and her lens thickness of 4.27 in both eyes. Her axial length in OD was 14.85 and OS 14.89. Her average keratometry in both eyes was 56, a very steep cornea. IOL power calculation by different formula varied from 49 diopters to 65 diopters. B-scan showed a thick chorioscleral complex, 2.06 mm in the right eye and 2.23 mm in the left eye. On conclusion, it was an extremely short eye, a very steep cornea, a very shallow anterior chamber, and a normal lens thickness, almost 1/4 of the whole eye. A thick chorioscleral complex, so a nan-ophthalmic eye, or shall I say, a pic ophthalmic eye. Set the wheels rolling, made many calls, wrote emails, asked, discussed, thought, and reviewed literature. The patient was planned for clear lens extraction. Decided to go ahead with a customized hydrophilic foldable IOL of 65 diopters to be injected through a small incision of 3.4 millimeters. The challenges faced is IOL power calculation, manufacturing a customized high diopter power IOL, and injecting the same safely through a small incision. Well aware of the various complications known in non-ophthalmic eyes, adequate precautions were taken before, during and after surgery. Patient taken up for femto, rhexis and a 4-quadrant division of lens performed. A 0.75 millimeter side port incision made and a gentle release of the aqueous, replaced by an OVD. Using a microrhexis forceps, the CCC was grasped out. Bimanual IA used for aspirating the lens material. Globe not allowed to collapse because of the use of the OVD. Main incision of 3.4 millimeter made. 65 diopter, highest ever IOL manufactured, was loaded, placed in the cartridge and then injected. Loaded the hydrophilic IOL. Significant amount of pressure needed to push the 1.9 millimeter thick IOL through a 3.4 millimeter cartridge. Precaution taken to not let the globe collapse. IOL placed in the bag and the trailing haptic dialed into the bag. Suture placed, bimanual IA done for OVD removal. Air placed, post-operatively, overwhelmed to see the first day post-operative visual acuity of 20/60 and a refractive error of -1.5 spherical with a -1.75 cylinder at 20. A second interesting case, post-traumatic hypermature cataract, referred for management. On examination, her BCVA in the right eye was 20/60, in the left eye PL and PR accurate. Her IOP was normal in both eyes. On slit lamp examination of the right eye, revealed microcornea with iris coloboma and nystagmus and a normal retina. Left eye examination revealed microcornea with an iris coloboma, nystagmus and a traumatic hypermature cataract. Low retinal view was possible. On examination, the white to white was 6 mm in the left eye and the IOL power was 29 diopters. On conclusion, we are dealing with a complex microophthalmos with iris coloboma and with a traumatic cataract. With the help of the caliper, we measured the corneal diameter, 6 millimeters. For adequate exposure, 2 iris hooks were placed. Main incision of 2.6 mm made and the capsule was stained. The rhexis was made with a micro-rhexis forceps. Bimanual IA for the soft lens material was done. The opaque plaque inferiorly in the area of the iris coloboma was left as it would help the patient to filter off the extra light. Post-op. 29 diopter hydrophobic IOL was taken, but it would not fit in the eye. So decided to cut the haptics and just place the optical disc in the bag. The challenging part was to load the disc in the cartridge and inject it into the bag. The only injector that worked was the sensor injector. Loading the optic disc in the cartridge. Placing the optic disc in the bag. Followed by bimanual IA. Let's look at the first day post-op picture. Notice the optic disc sitting well in the bag. conclusion, a comprehensive approach for such challenging cases like non-ophthalmos or micro-ophthalmos can have good visual outcomes. Thank you.
Thank you, Dr. Kumar. That was really wonderful. But Dr. Kumar, tell me one thing. In such nano-ophthalmic eyes, the potential risk is always there of an expulsive, right? And that is because of the thickened sclera and back pressure and all that. So you throughout the movement, there are always moments when the pressure would go down, despite the fact that you keep filling up the chamber with viscoelastic. So people have recommended so many things like spiral incisions or anterior chamber maintainers or something, but you didn't use any of that. It,
lot of discussion.
what is the message to the other people?
Yeah, so I agree with you. I had a lot of discussion. Initially, some years back, I had used the scleral relaxing incision. But I think what helped us here was a femto, in the sense I got my rexis fut, so there was no collapse at that level. And then with better viscoelastics now, because you are using Hilon GV, the chamber is always well maintained. And of course, it's a very soft cataract. In fact, you'll be surprised that the surgery took hardly any time, but the femto took very long, because the femto got all confused because the spherophakia is so much and the K reading is not recognized by the catalyst. So the catalyst got completely confused as to where is the cornea, where is the keratometry. So this is what I found as a difficulty. But I think what helped me was not allowing the chamber to collapse at all. And with new viscoelastics, I think we can get away with it.
Why not use an anterior chamber maintainer? Why not use an anterior chamber maintainer with a bottle with an IOP of 30?
I could have done it, but I still felt I will get away with it, and I did get away with it. So that's good. And she's coming for the other eye, in fact. You'll be surprised that the refractive error further changed after some time. It didn't remain 1.5, it became 2.5. And then I did a surface laser for her, and she's fine today.
Fantastic. That is really wonderful. Great. Dr. Bhalla?
Yeah, I think that was a really great talk and with excellent videos, Dr. Kumar. Glad to have you here, sir. Now, it's my proud privilege to invite my colleague from, again, scientific committee, Dr. Amit Porwal, to deliver his talk on phaco-trabeculectomy. Over to you, Amit.
Thank you, Dr. Balla, for inviting me to this galaxy of speakers, the International Ophthalmology Conclave. Am I audible?
Yeah, you are. Please carry on.
So my talk is on phaco-trabeculectomy. So we all know that cataract and glaucoma is one of the leading cause of blindness worldwide. It is the most common ocular condition associated with the aging process. And the prevalence is increasing due to increase in the lifespan. So there is also an increased risk of nuclear sclerotic cataract with elevated IOP and also with glaucoma medications. So why do we consider or think of phaco-trab? Phaco-trab basically is a combined surgery wherein cataract and glaucoma, both these issues are addressed in a single surgery. So it provides early visual rehabilitation of the patient with cataract and glaucoma. It reduces the risk of severe post-operative pressure elevation, may provide long-term reduction of IOP and decrease the need of glaucoma medications. So what are the indications for doing a phaco-trab? So there should be a cataract in a glaucoma patient who is having failure to achieve target pressures by medications. There are issues related to compliance and adherence to medical therapy. There is an adequate IOP control, but significant drug-induced side effects. There is a borderline controlled IOP with the disease progression on near maximum medical therapy, and there is an advanced glaucoma damage. So basically, these are the indications of phaco-trab. When we look at the preoperative considerations, there should be a significant visual loss which has to be understood and addressed to the patient that is it due to cataract or glaucoma. Because cataract visual loss can be regained, but the vision loss which is there due to glaucoma can't be regained back. So this has to be counseled to the patient before the surgery. So we have to try to understand what is the reason for the significant visual loss. On scan examination, we have to look for pseudo-exfoliation. If the antechamber is shallow, we have to be prepared accordingly and look for the myotic people, because most of the patients who are on phyllocarbon therapy, you will have a small rigid pupil, and we have to be prepared to handle this situation. Fundus examination is done to understand the amount of glaucomatous optic neuropathy and also if there is any other macular or retinal pathology which is associated with it. So special considerations in combined surgery, that is phaco-trab, is especially when we encounter a myotic people, there is an irreversible myosis. So we have to pre-plan before the surgery. How are we going to manage this myotic people? So there are these pupil expansion devices like the rings, hooks, and expanders, and we have to be prepared with one of these devices, and we should be well versed of implanting this. Coming to the viscoelastic substance, sodium hyaluronic, it maintains the flat anterior tonsil and deepens the AC. It should be thoroughly washed at the end to avoid post-operative IOP spikes. And HPMC, it causes less post-operative IOP elevation compared to the high-density viscoelastic substance. So these are the choice of viscoelastic which I've been mentioned. Coming to the rexes, it is always adequate. It's 5 to 6 millimeter rexes. Coming to IOL selection, you can inject PMMA, acrylic or silicone IOL. In case of no capsular support, there's a big no for AC IOL. AC IOL has to be avoided when you're doing a phaco-trabeculectomy. You can use an iris lens. And coming to the techniques of combined cataract surgery plus trabeculectomy, we have the single site technique and the twin site technique. So phaco-trabeculectomy can be done as a single site or a twin site. But whereas SICS trab, if you're planning, it has to be done only as a single site technique. So I'm going to show 2 videos of a single site and a twin site phaco-trabeculectomy. So this was a case of trabeculectomy with phacoemulsification in a case of small pupil, and this small pupil was addressed using malignant ring pupil expansion device. So always after taking a superior rectus suture, you mark the conjunctiva and usually take 3.5 to 4 millimeters. And once the conjunctiva is marked with the help of a conjunctival scissor, you do a subconjunctival dissection. You dissect the conjunctiva as much posteriorly and behind as possible so as to have a diffuse blood. So after the conjunctival flap is made, you cauterize all the bleeders. You have to identify the bleeders and cauterize that. You don't do a vague diffuse cautery. Always try to identify the bleeders and cauterize only the bleeders. If you are planning to use antimicrobial, I always advocate that you use a metal sponge. You soak it into micromycin, and the dose and the duration depends on the choice what we are with. And once you use the micromycin, wash it thoroughly. You have to make sure that everything is washed thoroughly, and never use cotton swabs to use antimicrobial because you don't want any cotton fiber to be left over because that can cause scleral necrosis. Next step is to mark the scleral flap again 3.5 millimeter at the limbus and about 3 millimeter at the apical end. I am always using a triangular flap, so you can use a triangular or a rectangular flap. With help of a 15 number plate, you raise the apex of the triangular flap, and once this flap is created, now for this train strategy, you shift temporarily. So you can see now I shifted temporarily. It is a case of complicated cataracts post uveitic. There is a small pupil. I have done a cyanocolysis after injecting dye under the air bubble and after injecting sodium hyaluronic. So after doing cyanocolysis, also the pupil was not dilated much. So after making the main corneal incision, I plan to use the malignant ring. Now the beauty of this pupil expansion device is that use a malignant ring DX or the OAS iris expander is that it can be injected through the same opening. The same main incision what you have done, so that you can inject this device and then fix it against the pupillary border. So there are different techniques for the different devices. So ultimately, the main aim of all these devices is that you should have a 5.5 to 6 millimeter centered well dilated pupil. So with this device, you can see that the pupil is now nicely dilated and maintained. These devices lie at the pupillary plane, so that is a great advantage. You don't have any peripheral shallowing of the anterior or anything. And now you proceed with the normal phaco technique. Whichever technique you are well versed to or used to, you could proceed with that technique. After doing the rexes, I'm well versed with the stop and chop technique. That is the most comfortable technique I'm used to. So I do a stop and chop technique. And what I follow this dictum is whenever you're doing the phaco trap, I always do a slow motion phacoemulsification because I don't want much of fluid turbulence into the anterior chamber because I don't want any pigment dispersion because these pigments can clog up the trabecular meshwork also, and plus there is a lot of pigment dispersion which we don't want. So you lower the phaco settings and do a slow motion phacoemulsification. So once the cataract is emulsified and the cortex is washed, the IOL is injected, and now the IOL is injected into the capsular bag. And whenever you are doing a phaco, I always make sure that IOL is in the bag. And as a dictum, I always keep the haptic at 9 o'clock position. And this pupillary expansion device is now disengaged from the pupillary border and is reloaded into the injector and then taken out. Now coming back to the superior site, we have created the flap. Now you just have to make the internal ostium, that is do a trabeculectomy. You can do that with the Kelly's punch or 11 number blade or an MPR. So this is 2 by 1 internal ostium. I've done with the help of 11 number blade. Once this internal ostium is made, then the phacotrabeculectomy is done. Whenever I'm doing a phaco-trab, earlier I used to take one intermediate suture and two releasable suture. But now I'm taking only one releasable suture. So as you go on doing your surgeries, you refine your technique and then you see what works well in your hand. And based on that, you go ahead with that. This is one of the earlier videos. So I've taken one intermittent apical suture of 10-0 electron. And now I'm putting a releasable suture. The technique of releasable suture again is very easy. You pass the suture parallel to the limbus clear cornea. Then from the color clear cornea into the spheral bed, perpendicular to the limbus, the next bite is passed, and then from the spheral flap into the interstitium. And you take 4 throws, the shoelace pattern throws, and tighten. Coming to the congenital closure, which is very important that you do a proper congenital closure technique. You anchor the congenital suture at the episcleral tissue or at the limbus so that the blood doesn't get retracted posteriorly because of the late closure mechanism. There are always chances that the blood can get retracted posteriorly. So the two anchoring suture at the limbus is very important, and you should have a nice watertight closure on the congenital flap so that there is a posterior diffuse flap. So this was the twin side technique which I had shown, and coming to the single side technique, uh, everything is same in this. The only difference is that whatever triangular flap you have created superiorly, you after creating the flap, you enter into the anterior chamber. Okay, so this is the same thing what I'm showing the video. The initial steps are the same. So again, marking bleeder. This is very important. Coming to the mitomycin, as I told earlier also, mitomycin. This is very important. Whenever you want to cut the conjunctiva or the scleral flap, you always mark it with the caliper. This is very important so that you get uniformity in whatever you are doing. So once these steps are done, so use a buccal wet sponge. This is very important whenever you are creating the flap. This sponge absorbs any blood or any fluid which is there, and you get a nice, very clear scleral flap. So just touch the cutting edge of the 15 number blade at the scleral flap, and it gets cut automatically. And you get a uniform thickness flap. You can see on this that I'm just pulling the flap and touching the blade, and there's a uniform thickness scleral flap which is created. So once this scleral flap is created, then now the thing is, after making the side port, is a single side phaco-trab. You enter the anterior chamber through this little flap. And now once you have entered this, you are going to do the phacoemulsification to the same superior side now. So all your steps remain the same. All the precautions of phacoemulsification which I had discussed in my previous video is followed. So you are doing the phacoemulsification to the same side. So only thing is, earlier it was said that the success rate of a single site is less than the twin site because of the energy which is there, thermal energy which is released at the phacocyte at the due to the probe that causes failure of the bleb. But when we look at the studies, there's no statistically significant difference between the IOP reduction whether you do a single site or a twin site technique. So this was a single site technique. You can see I'm using only a single releasable suture which is passed through the apex of the scleral flap. So basically, this is the only difference between the single site and the twin site. What is more important is how do you do the surgery? Meticulous planning has to be done. Your tissue handling should be very nice and delicate and gentle. Your cautery should not be a vague, diffuse cautery. You should identify the bleeders and cauterize only those. Coming to the antimetabolite, you should always use sponges. Count the number of sponges that you are going to place subconjunctivally, and when you remove also count them and remove so that you don't leave anything behind. And always wash thoroughly all your mitomycin. Never leave any traces of mitomycin. When you are making the internal ostium, you can do it with the help of 11 number blade, a Kelly sponge, or an MVR. So whatever is your preferred technique, you can do that. This is what I was talking about, the anchoring of the congenital flap. You take the episcleral or the limbal bite and anchor the conjunctiva. Intermittent locking sutures are put when you do the congenital closure. So these are the few steps which I was discussing in these two videos. And as I said, a meticulous surgery, well-planned surgery gives a very good post-operative result. And here I end my presentation by showing these two videos of single site and twin site phaco-trab. Thank you. Thank you, Dr. Bhalla, Dr. Chaudhary, and everybody for giving me a platform to present my talk on this topic. Thank you.
Thank you, Dr. Porwal, for a wonderful presentation. Dr. Porwal, can I ask a short question from you?
Yeah.
While doing a phacoemulsification in these very advanced glaucomatous situations where the nerve is very friable, what kind of an IOP precaution do you take during surgery? And how do you manage this situations?
Yeah. So the first thing is, if you are doing a topical phaco-trap, that's well and good. But most of us do our trap surgeries in block. So you have to make sure that you don't give an excessive block and don't give an excessive massage. Now, if you are using a Centurion, you can target the pressure to 25-30. But I am using an Infinity, so that's the reason. One of the reason I said was slow motion phacoemulsification. I lower my bottle height to say about 50 to 60, and all my parameters are slow. I take a lot of time while emulsifying the cataract. So this is what I usually do. Like, avoid excessive massage. Don't inject too much of visco. If possible, you can use a subtenance anesthesia that works well instead of being a peribulbar block, and use a slow motion phacoemulsification. And plus, in excessive glaucomatous optic atrophy, pre-operatively, you have to counsel your patient regarding the snuff-off phenomenon, which is very, very important. Even though the chances are less of the snuff-off phenomenon, you should always discuss and write this in your case sheet that this snuff-off phenomenon has been explained to the patient and about the chances of he also going through the same.
So I was having a discussion with one of the glaucoma people who said that if you keep the bottle height at 40, the inflow of fluid is so less that you will have fluctuation in the chambers and the posterior capsule would be at risk. So somebody suggested that why not use two inflows, one an anterior chamber maintainer and a low bottle height, so that you have double the inflow to take care of that fluctuation.
So any excessive inflow into the anterior chamber is going to increase the IOP. See, if you increase the bottle height to 100, the IOP is too high. If you decrease the bottle height to 50 or 60, the bottle height is less. Now, when you have two inflow going into it, so even if you are using an anterior chamber maintainer, you are going to use it from a height. The flow
If
which is
both
going
the
to come.
bottles are at a height of 50, then the IOP would be 30 only, but more inflow coming in the moment there is a pressure drop.
So whatever is coming in has to go out. There has to be a balance. So by putting two inflow and you are using only one phaco probe, and if you are doing a slow motion phacoemulsification, you are going to deepen the AC. That's true, but there's an excessive fluid collection into the anterior chamber. So there's no balance between the inflow and the outflow if you are using two irrigation port basically.
Okay, Dr. Harbas, you have something to say? You are still muted, Dr. Harbas. Can you please unmute yourself?
So I do all my trabees under topical, whether I'm doing phaco or not. And I give just 0.1 ml of xylocaine at the site where I have got to do the trabeculectomy. I do two sites so that the sclera is anesthetized. When you're doing cartilage, that is the only portion which is painful. So if you do under topical, so that pain is taken care of. As far as the IOP is concerned, because most of these wounds will be leaking because you have put on a side port chopper from where the fluid is coming, even from the main port fluid is coming. So most of the time when your phaco is in, even if your bottle height is 90, 80, 100, it is not that watertight, you are holding on to it and nothing is being coming out. So IOP will not rise, and most of the phaco are very short procedures. So I don't think it really concerns. I think more of a concern is when you give the adrenaline to these patients, and you give a peribulbar block with Adeline, I think that should be more concerned. So I think Adeline should be avoided and massage and peribulbar block should be avoided at all costs.
Actually, fluctuation of the chamber is more of a problem in trabeculectomies where there is a possibility of snuff out. So if you maintain the chamber without much fluctuation and do a very rapid phaco like what Harbin was saying, so the time of the surgery also matters. So I don't think there's much, because we do quite a lot of this phaco traps, and I've not had a snuff out, touch wood, all these years.
And even I never had.
Right. Thank you. So with this, we call Dr. Sujata, ma'am, Dr. Sujata from Chennai. She will be talking to us on phacoemulsification in compromised corneas. Ma'am, over to you, please.
Yeah. Okay, you got it?
Yeah.
Yeah.
1 minute. Okay. At the outset, I'd like to thank Dr. Namrata and the AIOS for giving me this opportunity. So I'm just going to quickly go through some of the situations where we're going to have difficulty when you're combining phacoemulsification with a corneal problem. So any local cause such as pterygium, spheroidal degeneration, keratoconus, systemic diseases that can affect the cornea like collagen vascular disorder, post-refractive surgery, a previously operated eye, and of course an endothelial problem could also be are some of the problems that we can face. So the pre-op evaluation, the pearls would be documentation of the corneal pathology is very important, specular microscopy in case of endothelial disease, systemic evaluation, particularly collagen vascular disorders, and pachymetry to determine whether the patient needs a combined procedure or not, and corneal biomechanics and topography in patients with keratoconus and PMD for determining the toric IOL power calculation. So the most important thing in a combined problem is that you have to inform the patient that it's not the cataract which is alone causing the drop in vision, but because of some of the compromised cornea, you're also having defective vision. So this is a very important thing that you have to emphasize to the patient, and also tell them the risks involved in compromised corneas, the difficulties during surgery, and the prognosis of the outcome. So there are several problems as simple as epithelial problems like EBMD, dry eye, post-herpetic corneas, patients with Bell's palsy with exposure keratitis, post-archic corneas, post-PK corneas, Fuchs dystrophy, and keratoconus. Herpetic corneas, we all know it's better to avoid during active ulceration, and the most important thing in these patients is to prevent recurrence, because post-operative use of steroids can always cause a recurrence. So good lubrication and antiviral prophylaxis may be required, and particularly in patients who have recurrent incidences. So Bell's palsy again is a problem because of the poor lid closure. You can see that already the cornea is very much damaged. So it's important either you do a lateral tarsography before and improve the health of the cornea. You can remove the lateral tarsography during the procedure, during the cataract procedure, and then retape or advise patient to tape or redo the tarsography post cataract surgery. But the most important thing is that you have to take care of the cornea before. Corneal scars are a problem because you know that the cataract has to be done, and you know the opacity has to come out. So it's a combined procedure is definitely needed. So what type of IOL power calculation that you're going to do will be the most challenging thing. Either you can use a keratometry from the other eye, but most of us prefer to use an average of 43 or 44 diopters. But if the cataract can wait, then you can go ahead with a keratoplasty is the first stage, and stage your cataract a little bit later, so that you will have some amount of idea about the keratometry of the cornea. So this is one of my patients who had a 14 diopter after a DALC for a keratoconus, and after suture removal, she dropped to 7 diopters, and she needed a customized IOL. And the most important thing is that in post-PK or DALC surgery, maintaining the post-operative clarity of the graft is also very important. So good viscoelastics need to be used. Ocular surface compromise, anything which can cause corneal anesthesia, such as immune ulcers, contact lens abuse, topical drug toxicity, neurotrophic dry eye, have to be dealt with before taking up the patient for cataract surgery. So rheumatology opinion, control of systemic parameters, the need for long-term steroids, and the care about NSAIDs, and discussing with the patient the need for frequent follow-up is very important before taking up these patients. You can see the ocular surface, which is very badly damaged, which needs to be improved before taking up the patient for cataract surgery. As far as endothelial disease is concerned, this is something which we come across very often. So the question is whether we do a combined surgery or just go ahead with a cataract alone. It depends upon the amount of involvement of the endothelium. So if you're just doing a cataract surgery, use abundant viscoelastic, use a soft shell technique, a low phaco power, and whole phaco techniques. You can do an SIC as an ECC in very hard cataracts. However, if you're doing a combined surgery, usually the decision is made upon how symptomatic the patient is, the amount of blurring, whether the pachymetry is more than 600 microns, presence of bull layer epithelial edema, and also the density of the cataract. If the cataract is very dense, you know that the patient is going to lose more endothelial cells, and it's better to do a combined surgery. So we all know the routine phaco loss is 6.3 to 12.8%. So taking care to make sure that when you're doing a routine cataract surgery in a patient with endothelial cell compromise, you do an in-the-bag phaco and use a high-density viscoelastic and a soft shell technique, and use cold phaco technology to reduce endothelial cell loss. So other considerations are scleral tunnel incisions, and avoid patients, just make sure that patients who have other problems such as EBMD and anterior corneal dystrophies should be taken care of. So this is one of my patients who had a DSEC in a Fuchs endothelial dystrophy. You see how beautifully the epithelium has come off. And once epitheliorhexis has been done, you can see a very clear anterior chamber. You can visualize the lens very nicely. And you can go ahead with a phaco, routine phaco. You don't really have to worry about the endothelium in this case, because I'm going to do an lamellar transplant. And we can actually use a trypan blue because it gives better visualization. And in this case, I've not used it. And gentle phacoemulsification. You don't want to have any complications in these procedures because you're planning a triple procedure. You just want to make sure that everything goes on well. And I use an anterior chamber chopping technique. I chop in multiple pieces, and then I emulsify all the pieces one by one. I don't remove the pieces as we chop, and that is usually my technique. And once it is done, I do an IA. And fortunately, you can see that the visualization is excellent in this patient after removing the epithelium. And then you implant a lens, intraocular lens in the bag. So in these patients, the next stage would be to mark the center of the cornea so that you make sure that that you're well-centered, your graft is centered. Use a reverse Sinski to score the endothelium all around. And you can keep the pupils dilated, because then you can see very nicely how the endothelium is peeling off. In patients who have Fuchs, usually it peels off very nicely, a single piece. It's like more like a desmotorexis, and it comes out very nicely. But in patients who have PBK, usually there'll be a lot of scarring and it'll be difficult to get them out in one single piece, like you see here. And once the endothelium is removed, completely remove the viscoelastic. Go under the lens, remove the viscoelastic, and make sure there's no viscoelastic remnant. Do a small PI, inferior PI, because you're going to fill the bag with air. And my technique of doing a DSEC is a push through technique. Here I'm using a sheets glide to keep the cornea, the disc of the cornea, which has been prepared already. So the top layer is removed and only the endothelium with a little bit of stroma is remaining behind. And I'm using a 26 gauge needle to do a push through technique. And you come out very gently, inject saline through the side port, and you can see that the graft is unfolding very nicely, and then inject air. It's always better to go to the center and inject, then the graft does not slip to the slides like what is done. You can use a reverse Sinski to center the graft and fill it up with air. This is a post-operative outcome of this patient. As you can see, a very clear graft in about a week's time. So this is again a patient, you can see a localized corneal edema, again a patient with Fuchs, a combined surgery. Most often when you do a combined surgery, like this talk demands a phaco with, this is the indication is mainly Fuchs, because we don't, all the other indications are usually pseudophakic bullous keratopathy where the lens has already been removed. And that's why I have to show you another case of Fuchs. So this cataract has come out very nicely. This is even in patients who have very early cataracts like this, as you can see here, probably grade 1, which probably wouldn't be operating. It's better to remove them because you don't want to go inside once the graft is in place, because you don't want any more endothelial cell loss. So it is better, unless the patient is a very young patient, has an absolutely clear lens, then you can do a DSEC without removing the lens. So here again, you're getting a nice red glow, and you can see that the margin of the endothelium being stripped off very nicely. You can visualize it, and I prefer to do it under viscoelastic because it gives us better control. The AC does not shallow. You can also do it under air because it also gives good visualization, and you can just come out very nicely. It's a single piece, and then again, you go inside and remove all the viscoelastic completely and then inject air. I'm doing a PI, inferior PI, and again, a push through technique. Inject saline. and that's the end of the case.
I'm short again.
Yeah. So this is again another patient, with who needed a phaco-desec with hard cataract and a small pupil. So I went ahead and did a phaco, as you can see. Patient had a very floppy iris, but that's why I had to put a pre-placed sutures. Ultimately, the patient turned out very well. I have about 6-year follow-up on this patient. So these are some of the problems that you don't anticipate, because I didn't expect the patient to have a floppy iris at all. But fortunately, everything went off very well, and the disc that came out very well, and the disc was unfolded beautifully, and the outcome was good. So these are some of our patients who had a phaco-desec. And the other things that we look for is another compromised cornea that we're speaking about is a radial keratotomy, where not only the biometry is difficult, but also the chance of wound gaping, particularly when the incisions are much more than 8 incisions. It's going to be difficult to put your incisions, your side port incision or your main port incision can open out. The wound can gape, so it's very important to use adequate parameters, slow motion phaco, to make sure that the wound doesn't gape. And in post-LASIK patients, if the ablation is not well centered, it's always better to avoid multifocals. So I think my time is up. And to summarize, treat the ocular surface before cataract surgery, counsel the patient about the outcome. Post-keratoplasty, all sutures to be removed before cataract surgery probably gives the best results, but sometimes we may not be able to do it because the cataract matures much earlier than the sutures take up. So we may have to still do it. We go ahead and remove the cataract and do combined procedures whenever required. Thank you.
I think that was a wonderful talk, Dr. Sujata Mohan, where you made the whole thing look so easy. Now, I would like to invite Dr. Harbanslal. Dr. Harbanslal needs no introduction. He's a great phacosurgeon, excellent teacher, and a wonderful speaker. And is going to talk on toric surprise. What next? Over to you, Dr. Harbansal.
Can you see my presentation here?
No, sir, not yet.
Hello.
Yeah. Can you see now?
Yes sir, yes sir. सर बस इसको ओपन कर लीजिए फुल स्क्रीन में. हाँ बस अभी सर इसको फुल स्क्रीन मोड में रख दीजिए.
अभी दिख रहा है नहीं दिख रहा है?
हाँ सर दिख रहा है सर.
Okay, so I'll be talking toric IOL surprise. What next? So we put on a toric IOL, and if the patient still has got astigmatism, what are the options we have? Realignment of the toric IOL, exchange of IOL, piggyback IOL, or a laser correction. So whenever we want to do realignment, I will like to explain certain terminology. One is that we need to know after surgery, what is the total refractive astigmatism patient has got. What is a keratometric astigmatism now, not pre-operatively, post-operatively. What is the total correctable astigmatism by the IOL? And what is the residual non-correctable astigmatism? That means if suppose patient had a corneal astigmatism of 2 and you have put on a toric IOL which can correct only 1, that means one diopter cannot be corrected by the realignment of the toric IOL. And at the same time, we will like to know what is the residual correctable astigmatism. That means what was, if the IOL was in ideal position, how much it would correct and how much it is correcting. So we need to analyze these data before we can plan for realignment. And we always align the axis, misalignment, and the correction is the byproduct of that. So we need to know how much is the misalignment. As we know that the degree of misalignment, if it was 30 degree, the residual correctable astigmatism will be total correctable astigmatism. That means if the IOL is 30 degree misaligned off axis, there will be no effect of the IOL onto the corneal plane. With that in mind, if we know that how much is the misalignment. We know that if the misalignment is more than 10 degrees, then we can go in and try to correct it. Between 5 to 10 degrees is questionable, and below 5 degrees, we will not like to correct it because we are not 100% sure whether the realignment is going to help. So to find out the residual correctable astigmatism post-operatively, why I'm emphasizing whatever was the pre-operatively is gone. Now, after doing the main incision, whatever is the steep axis now is more important. So what is the total patient has got a refractive error, whether he has got -2, -1, -3. What is the corneal astigmatism at present? What is the steep axis and what is the astigmatism? And what is the IOL which can correct? Now, let's say if the patient has got a total correctable astigmatism, that means IOL can, I have taken it in very simplified manner, is one diopter at a corneal plane. And if there is a residual astigmatism of 0.5 diopter, that means the misalignment is by 15 degree. And if it is a 2 diopter lens, then 0.5 diopter of correctable astigmatism is, that means misalignment is only 7.5 degree. But if it is a 3 diopter, it is 5 degree. If it is a 4 diopter, it is 3.75 degree. And if it is 6 diopter correctable IOL, and if there is a 0.5 diopter residual astigmatism, actually misalignment is only of 2.5 degree. That means, and if you take a 1 diopter, usually we don't correct 0.5 diopter. A 6 diopter IOL giving an error or under correction of 1 diopter, actually misalignment is only by 5 degree. While 1 diopter IOL, 1.5 diopter IOL, which is correcting 1 diopter, misalignment is by 30 degree. That means the 1 diopter IOL, which is giving 30 degree misalignment, can be corrected, but the 6 diopter IOL, which is correcting the misalignment error of 1 diopter, only 5 degree of misalignment, probably you will not attempt. So it is very important to understand in relationship what we have achieved and what we should have achieved. That proportion is very, very important. So realignment is done when there is significant misalignment, and it can be corrected significantly. So now I'll give you one example of my patient, 67 years male. On 21st of January, the lens star reading was 1.39 at 92 degree. Pentacam at 3 millimeter was 1.5 at 93.5. This was total corneal refractive power. And when they saw the patient on 6th, it was a multifocal toric IOL. Uncorrected distance visual acuity was 618. Best corrected visual acuity with 1 diopter of spherical minus 1 diopter slender at 30 degree was 6.6. And then we again calculated the keratometry. At present, the lens SR keratometry was 1.56 at 94, and pentacam at 3 millimeter was 1.6 at 95. Because Indian people are little smaller, so I go by 3 millimeter most of the time. But at 4 millimeter, it was just 1.1, and it was 81.4 degree. So correction achieved by the IOL was more or less 0, and you can see the IOL is mispositioned. So we plan for the reposition of the IOL to the present steep axis. I'm emphasizing again and again that you don't have to really go to the astigmatismfix.com or ASSORT or any other site, because whatever is the steep axis now, you put the IOL there. If you feel, unless your surgical induced astigmatism is too high, and you don't have to open the main port incision, just make the side port incision and implant the. So now if you see this, there is a mark on this, which is I'm marking now 90 degree, and with the 92, 93 at 3 millimeter and 81 at 4 millimeter, I'll be quite comfortable putting this lens at 90 degree. So my way of marking is I take a chopper, give the indentation over there with the chopper, and then put on an ink which stays there longer, or even you can put this chopper into the marking pen and mark over there. And then I put on an ink over there. So this axis is now being marked where I want my L to align. Though I took this picture on a slit lamp with the app available, and it showed 42 degree misalignment. But to my mind, that is not important. until unless the astigmatism is too irregular and you are not sure. So I prefer to put it, the side port incision is open, which was made earlier, nearly a week, 10 days earlier at the time of surgery. You make another side port incision. I usually make one side port incision. Hyaluronic acid is the preferred viscoelastic over here. I go underneath the rim of the anterior capsule and inject little bit of viscoelastic over there. And this lens is, at present, the capsule is, you can see the capsule is not so fibrous. There is no whiteness. So lens can be very easily lifted. So I put on a viscoelastic in the bag. And then this lens is redialed into the position. You can do the hydro redialing also as we do the hydro implantation. But I'll prefer to use the hyaluronic acid over there for the better separation of the capsular bag can be done. So you can see that one loop is being moved, but the other loop has not rotated because of the knee, which is very flexible. We separate the anterior and posterior capsule by sweeping with the iris repulsor. Then we go and separate if by any chance there are any other additions onto this side. And the same iris repulsor is used to dial this lens into the new position. And we know that the lenses are to be dialed into the clockwise position, even if you need to dial more. And make sure that there are no additions and they should be lifted up and well. So now I use a dumbbell dialer to position it. And once this lens comes into the position, we need to remove all the viscoelastic, whatever is there. And particularly if there is anything behind the lens, that has to be definitely removed. So we position the lens. And the lens is now at a right position. We remove the viscoelastic. You can see a small air bubble behind the lens. That also shows that there may be some amount of viscoelastic behind. So we go lift the lens, go underneath and take it out. I really don't want this lens to rotate again, otherwise I'll have to go and rotate 180 degree once again. If need be, of course, you will have to do that. There should be no doubt about that. And once this is done, viscoelastic is removed. We inject the air before coming out so that the lens is pressed and make sure that your wound is well sealed. I put on antibiotic drops again over here, put some air and press on both the sides with the swab stick to make sure that the wound is well sealed and the surgery is over. So this residual refractive error in this patient was 0.25 diopter spherical and 6.6. There was no astigmatism. Pre-alignment was +1 with the -1.5, and this spherical equivalent was 0.25. -1.5 cylinder is equivalent to -0.75. This is very important to understand the spherical equivalent because non-correctable astigmatism, realignment will not work if this spectral error is more. That means if the patient has got 2 diopter of corneal astigmatism and you have put on a lens which corrects 3 diopter or 1 diopter, it is not going to work. Or if the spherical equivalent, that means patient had -1 diopter of spherical and -1 diopter of cylindrical, total spherical equivalent is -1.5. That means the spherical equivalent is going to remain the same. It is only which is astigmatism is going to change. So if there is a refractive error, it is not going to be corrected by the realignment of the IOL. If there is an irregular astigmatism, it is not going to work. If there is a junior dialysis, PCT, or the fibrosis of the capsule, sometimes if the capsule is too fibrous, maybe after 3 months or so, it may be very, very difficult to place the lens into the new position because the separation of the capsule may be very difficult. So it is better to do it early on. And other options are, of course, laser, which could be LASIK or PRK after 3 months. And particularly, there is a high spherical equivalent. That means if there is a refractive error along with the astigmatic error, and if there is a non-correctable astigmatism, then this is the best option. And IOL exchange, I prefer in a hyperopic spherical equivalent. That means if the patient has a hyperopic, now if the lens has been put underpowered and he has got a +1, +2 because the LASIK may not work so well in hyperopic patients. And piggyback IOL can be used in the reversible option if there is irregular acceptance, the patient is not interested in any contact lenses and spectacle, and you want to see whether the toric ICL or toric IOL works over there, and if patient is not happy, you can remove it, then piggyback IOL can be used. Now, otherwise, the laser, if you got an option of a laser, I think it works very well. And thank you very much for your kind attention, and any other comments from the panelists?
Thank you, Dr. Harbans, for a wonderful presentation. You've really shown us all the aspects of toric IOL getting misaligned and how to bring it back into position. For a little paucity of time, we have two speakers, but I think Dr. Sonu Goel is not here. So may I invite none other than Dr. Bhalla, who is also the co-chairman of the session, to make his presentation.
Yeah, thank you everyone. Thank you AIOS and Dr. Sanjay. And thank you all the esteemed speakers and seniors for their wonderful talks. I'm going to talk on negative dysphotopsia. Let's try to unravel the enigma. We all know that there are two kinds of light. The glow that illuminates also causes the glare that obscures. Imagine you have just performed a successful uncomplicated cataract surgery and given patient vision of 6/6 and are ready to be congratulated. But instead, when your patient starts cribbing, "Doc, I hate these unwanted images that you have given me," of course, this is not what you wanted to hear. So what is dysphotopsia? These are undesired optical images associated with otherwise uncomplicated, successful IOL surgery, and it has become #1 problem following successful cataract surgery. Patients are incredibly unhappy and they move from one ophthalmologist chamber to another. And when they are told that nothing is wrong with them, they become more angry. So although this term is gaining acceptance, it's a misnomer. Why? Because photopsias are visual perceptions that arise in absence of light stimuli, whereas dysphotopsia do not occur in the absence of light stimuli. In the literature, terms such as photopsia and toric and photic phenomena has been used, and the term dysphotopsia was used for the first time by James Tester in June 2000. It's a Churchill's proverbial riddle wrapped in a mystery inside an enigma, because when the surgeons and patients are both frustrated, and when surgeons tell the patients that it will go away in time, it is not always 100% true. And these patients are, some of them are so angry that they have filed lawsuits against ophthalmologists and lens manufacturers. So let's consider what are these. Two major categories. Those arising from the optical surfaces are called a different variety, but those arising from the IOL edge, I'm going to cover. The positive dysphotopsia occur as edge reflections, and the negative ones are edge scotomas. We wanted some desirable traits in foldable lenses, but that had led to undesirable optical phenomena. We wanted thin lenses to go through small incision. It acts like a mirror. We wanted square edges to reduce PCO, but it causes internal reflections. We wanted hydrophobic lens because they have less rates of PCO, but they cause more dysphotopsia because of low anterior curvature and high refractive index. Truncation, bitruncation all lead to undesirable optical phenomena.
Dr. Bhalla, excuse me, please share your screen. We are not able to see the presentation.
Is it? Just a minute, ma'am. Is it visible now?
Yes.
Yeah. I'm so sorry, yeah, ma'am. Yeah, so the negative dysphotopsia was first reported in 2000 by James Davison, who likened this temporal darkness to horse blindness. It is commonest type of dysphotopsia, least understood, more debilitating than positive dysphotopsia, associated only with perfect surgery, and it's a sickle-shaped dark shadow or a crescent that gives the impression of a shade over the temporal peripheral region of the patient's vision. So why does it occur? You find here that temporal rays of light, when they strike against the nasal edge of the IOL, most of it is reflected back. Now, since there are no light rays to be refracted, you find that in the nasal periphery, you have a dark shadow, which is in crescentic form. And since it occurs because of that light coming from the temporal area, it causes temporal shadows in the temporal field of vision. Holliday has done a lot of ray tracing experiments, and he found that there are 3 types of shadows: type 1, type 2, and type 3 shadow. And it is the type 2 shadows which we are considering when you find that the rays of light coming from the interior surface, when they strike the posterior edge and the posterior surface, there is a shadow between the light rays which are refracted more from the posterior surface and less from the posterior edge. So this shadow is what is known as a temporal scotoma, which is known as temporal dysphotopsia. So the causes can be light from the far temporal field can miss the IOL and arrive anteriorly onto the nasal retina or on the visually insensitive pars plana region of the ciliary body, or light entering from the temporal periphery is reflected back. So low light rays available for refraction. And since the shadow is produced by light entering from the temporal visual field, that is the reason why it occurs only temporally. So this is negative dysphotopsia, what I was talking about. These are type 2 shadows and these are type 3 shadows. And this is a recent publication in May 2020, where they found that since these light rays which are coming from the temporal field of vision, and this is the shadow which is occurring. And what they did, a very interesting experiment was when they had a contact lens which had a annular opaque ring in the periphery of the contact lens, they found that they could cut off these negative shadows. So this is how they also again proved that this is the culprit, the temporal rays which are striking the nasal sharp edge of the IOLs. Another experiments have been done and published in JCRS 2017, where also they have done a lot of ray tracing experiments. So let's see what are the factors which are accountable for these kinds of dysphotopsia. Primary factors are small pupil, more distance behind the pupil between the iris and the IOL, and it has been calculated to be 0.06 to 1.2 millimeter for acrylic and 0.06 to 0.62 millimeter for silicone. A sharp edge design, functional nasal retina, and the secondary factors are high index of refraction as in hydrophobic IOLs, large angle alpha, nasal location of the pupil, transparent versus translucent state of the peripheral nasal capsule, and it is more common with high plus lenses. Why it occurs only temporally is because the light coming in nasally is tempered by the nose, eyebrow, and cheek. And secondly, nasal retina may extend further anteriorly than the temporal retina. These are some of the diagrams which have been drawn by the patients, and they find that this is the temporal crescentic shadow. So incidence of negative dysphotopsia, immediate incidence is about 20%, and the long-term dysphotopsia remains 1.5 to 3%. And it has been found that in about within 6 months to 2 years, the incidence remarkably comes down. So patient needs to be patient regarding these. These are the three types: transient, temporary, and persistent. Transient is the one which is resolved in 2 weeks, and the culprit is the hydration of the temporal clear corneal incision. Temporary is the one which gets resolved within 6 to 12 months due to the opacification of the peripheral rim of the anterior capsule, and also because of neuroadaptation. Persistent consists of lingering cases that annoys the patient and perplexes the surgeons. So it is associated with well-centered in the back PC IOLs. It does not occur with sulcus IOLs, does not occur with AC IOLs, does not occur with poorly centered IOLs. Lens incidence with 3P silicone IOLs increases with bright light, and symptoms, although present early, usually resolved by 6 months, and in 80% cases within 2 years. Dilate the pupil, problem resolves. Constrict the pupil, problem worsens. Since no medical therapy seems to work, surgical treatment may be required in these patients. So what are the surgical treatments? We can either remove the nasal annulus of the anterior capsule, which is supposed to be casting shadow on the retina. We can place shoulders of the haptics of 3-piece IOL horizontally. We can do reverse optic capture, piggyback IOL, and then there are some novel IOLs like by Masket and Tessignon, anti-dysphotopic and back in the lens IOLs, and some of the innovations have come from India. So this is what can be done. The peripheral rim of the anterior capsule can be, nasal rim of the anterior capsule can be yagged, and it has been found to be successful in some percentage of the cases. By placing the haptics horizontally, what is being now done is these haptics act as the continuation, extension of the optic, and so that there is no sharp edge and no shadow is being there. And this light from these optic haptic junction bleeds into this shadow so that this area becomes illuminated and the temporal crescentic shadow of dysphotopsia disappears. Reverse optic capture was advocated by Dr. Masket, where he teases off the IOL of the anterior capsule with a blunt instrument, so that instead of anterior capsule covering the IOL optic edge comes in front of the anterior capsule. So first, what is done is that the nasal edge of the IOL is lifted above the anterior capsule rim, then the temporal. And this is how this again goes to prove that in some of these cases, the culprit may be the shadow of the nasal anterior capsule. And as the anterior capsule opacifies, this may disappear in some of these patients. Then other thing is that we can have a piggyback IOL. How piggyback IOL helps? It by decreasing the distance between the iris and IOL, and then it covers the anterior capsule and the IOL edge. But that for these, the requirements are that the first surgery should have been uncomplicated with a well-centered in the back IOL without any evidence of zonulopathy. Masket came with a novel IOL, which is known as anti-dysphotopic IOL, wherein they have the groove on the edge of the optic into which rests the anterior capsular axis rim, so that again the shadow cast by anterior capsule is no longer there and negative dysphotopsia. And this has received FDA approval also. Bag in the lens IOL was advocated by Mary Tessignon, wherein we find that instead of the capsular bag supporting the IOL is supporting the anterior capsular axis and posterior capsular axis rim, so that the anterior posterior capsular axis rim are holding the IOL. Now, this was a very interesting publication by Prakhyat Roop, published in Indian Journal of Ophthalmology, wherein what he has done is that the IOL is, instead of being round, what you are finding is that the dimension of IOL is more horizontally than vertically, and the angle at which the haptics are being attached is also different. So what it does is that the optic axis and the visual axis are now coinciding with each other. So this shift in the optic along with the larger horizontal diameter may result in much less incidence of negative dysphotopsia. Another publication is by Shri Ganesh et al. In Indian Journal of Ophthalmology 2018, wherein they have come with a IOL which has 2 extra haptics on the optic at 3 and 9 o'clock positions made of PMMA, which can swivel over a pivot, and it acts like a clip and it is attached to the anterior capsular rim. So that what happens is, now since the distance between the iris and IOL is reduced, the negative dysphotopsia may disappear or may decrease in incidence, and this is the hypothesis of the authors. IOL exchange is the last resort if the symptoms do not resolve in 6 months, and then we have to consider lens exchange. The principles of IOL exchange are that the newer IOL has to be of lower refractive index, preferably silicon with rounded edge, optic diameter has to be large, and the surface reflectivity has to be low. More power has to be reduced to anterior surface and less to the posterior surfaces. So precise reasons why only certain percentage of patients encounter negative dysphotopsia and others don't still remain a mystery. Reverse optic capture and piggyback IOL implantation in the sulcus remain the most successful approaches for negative dysphotopsia. So the take-home message is surgeons need to know and recognize that dysphotopsia is a real, and please treat it as a legitimate problem. Don't fool the patient by saying that all is well. Yes, you can counsel the patient that all will be well. So dysphotopsias represent a failure of current day cataract surgery and needs to be assessed by alteration of surgical methods, IOL designs, or both. If we are able to remove these haunting images from the field of vision of these patients, then the smile will return back to the countenance of these distressed souls. Thank you everyone for your kind and patient hearing.
Thank you, Dr. Bhalla, for this really enlightening talk. And over the years, your talk is getting more and more informative and updated, and it's always a pleasure to listen to a new version of the same talk with so much of new inputs. Thank you. And since we are off time, I'll thank my co-chairman, Dr. Bhalla, and the faculty members, who all the presentations were wonderful, and the audience out there who was listening to these wonderful speakers. Thank you, everybody.
Thank you.
Thank you. Thank you, everyone. And sorry if I missed the initial part of my presentation. Thank you.
Thank you, sir. Thank you, everybody.
Thank you, ma'am.
Thank you. Thank you, Dr. Ragini, Dr. Swapna, Dr. Harbans Lal, sir, Dr. Ajay.
Thank you, Ajay. Thank you, Harbans. Thank you so much.
Take care, everybody. Be safe. Bye.
Bye.
Thank you, ma'am. Bye.
And Mumbai, be safe. We hear Mumbai is catching up again.
Yes, sir. We'll take care, sir. Thank you, sir. Bye.
Okay.
Bye, everybody.
ma'am.
Take
Bye.
care.